hit my head, so hopefully I won't do it again. I'm Matt Wilcox, as she mentioned. I'm a cardiologist here at U of M, Heart and Vascular, previously known as TCI. I've been with the group for 20 years, so it's been a wonderful experience in mid-Michigan. Grew up in St. John, so this is still home for me. So I always enjoy doing this and seeing a lot of friendly faces. If you're my patient and I don't bring it up, it's because of HIPAA. I'm not avoiding you. I just can't run around and say, hey, how are you feeling, okay? That gives away some stuff. So title for today, I was asked to talk about what would we talk about for healthy heart and vascular habits. Obviously, if you read the title, we like to call ourselves cardiologists, but we don't want to forget the fact that we are vascular doctors as well. So it's more than just the heart. It involves carotids, arteries in your abdomen, aneurysms, your legs, peripheral arterial disease as well. The good news is the risk factors and the treatments and a lot of the subject matter we'll talk about goes together for both. So if you have any questions, keep them till the end unless it's really pressing. We'll definitely have time at the end. She told me I had about 2.5 hours. So if we go long enough, maybe they'll serve you dinner too. So, all right. First thing we have to always put on in your talks, no disclosures. I'm not getting paid. No pharmaceutical companies are paying me for this, and I did not take any slides from pharmaceutical companies. I am not biased in this, and you'll quickly see it's not a pharmaceutical talk. Okay, so this is what we would like to avoid if we can help it, right? So this is a picture of blocked arteries in your heart on CAT scan. And it shows on A and B and C just different lesions where you can see the white is where the blood flow is supposed to be, and the black, unfortunately, is cholesterol, and the very bright white is calcium. So we get these calcium scores or cardiac CTs, and we're able to non-invasively look at the arteries of your heart and be able to tell you if you have a blockage. So this is the process we're trying to avoid or at least prolong. Try to get this as long down the road as possible, right? Obviously, also, we would like to avoid, there's a little delay, the second part of this, which is a CAT scan on your left and an MRI on the right, which shows the obvious abnormalities of the obvious joke about the radiology sign, which is the arrows, which shows you the large stroke in the brain. So these are the scenarios we're trying to avoid by what our talk is today. There's nothing more devastating than a giant stroke, and we'd really like to avoid heart attacks as well as possible. So I always open up every lecture when I talk to the fellows and the residents when I train them is, why do we care? Why does this lecture matter? You know, what about this is important to people that you should be talking to about why they want to spend 40 minutes listening? Well, unfortunately, each year there's about 700,000 deaths from heart and vascular related death in the United States, still the #1 cause of death in the country. And when you take that out and extrapolate it out, you look at there's 800,000 heart attacks in the United States. 600,000 of those are first-time events. So 600,000 new heart attacks every year in the United States. And unfortunately, of the 800,000 total, 300,000 of those people will succumb or die from the heart attack. So you'd like to think, well, our technology is amazing. I can take you into the cath lab and show you what my amazing partners do with stents and angioplasty, and it's fantastic. But unfortunately, many of these people don't even make it to the cath lab, right? So they pass away at home or in the ambulance ride in. So we're trying to avoid those deaths. So that's obviously why this matters. 26% of women will die from heart attack, and 19% of men. So even if you don't die immediately, there's still that risk in the first year. And this is why when we talk about some of these risk factors that we're going to go over, why it's if first heart attack. Of women will have a stroke, heart failure, or die within 5 years of having that heart attack. So you can see there's not many cancers that you have a less than 5 year, that half the people will die at 5 years. We implement a lot of what we're talking about. 800,000 strokes per year. Stroke itself is the third leading cause of death behind heart disease. So that's why when you add them together, obviously they're #1. And the cost of the United States system right now is estimated at $500 billion for this year. You can imagine with an aging population, a population in my generation, unfortunately, that doesn't look as like exercise and weight. My generation is definitely heavier, so those signs are not going to get better, right? So we really need to try to address this and see how can we implement things early to try to help people and frankly, help the system. So what are those risk factors for heart disease and stroke? Well, we pretty much know them. We know them. They're hypertension, high cholesterol, tobacco abuse, sedentary lifestyle, central obesity, excessive alcohol, and then the one you can't modify, which is family history. You can't change your parents, right? So genetically, what you get, I'll give you credit for. You can't alter that, all right? But the rest of these, we can have and play a role in. We can positively or negatively affect all of these other aspects. We can't change, well, we can't change our gender for the purpose of this speech, and we can't change the fact that we're going to age, and we can't change our family history. Everything else that comes down to risk factors is modifiable, is what we teach the residents. So, what first? First and foremost, tobacco cessation. This is first and foremost the first lecture that patients are going to get from me in the office. I'm nice about it. I joke that even my own kids don't listen, so I don't yell. But this, if you want to change your outcomes in the next 50 days, 5 years, 15 years, this is how you do it. So they did a nice study in 2022. And they talked to like 1,000 people who were smokers. 2/3 of them acknowledged that they wanted to quit. 67% of the people on the initial intake said, we want to quit smoking. Fantastic. Probably goes along with my practice. 1/3 are really nice. Thank you, doc, but no, I'm still smoking. Okay, it's a choice. And you can make that choice, and that's fine. Less than 10% of the people that tried, 50% of them attempted to quit. Less than 10% were successful at a year. It's actually 7.8%, but I put less than 10 to be generous. 7.8% of the people were able to quit at 1 year. Now, does that mean we give up on them? Of course not, because if 7.8% quit this year and another 7.8 quit next year and another 7.8 quit next year, you're getting to where you want to go, because in the grand scheme of things, eventually 60% roughly people do quit smoking. So you just got to take the numerous years of that, right? If I won't do this to call anybody out, but if I had a raise of hands in here and ask how many people smoked in their 20s and 30s and how many still do now, obviously those would be grossly different numbers, right? I don't blame your generation. I always joke, your generation was lied to and didn't know. My generation and below knows the truth about tobacco, and we have no excuse, okay? So why is it important? There's a 50% reduction in mortality, which is the word for dying, in those people who smoke after their first heart attack or stroke. You have a 50% chance less of dying. It's in the first 1 to 5 years, but 50% less chance of dying. So when you add up all the medicines we give you when you come in after a heart attack, they don't add up to the same benefit as stopping smoking. So I literally could tell you, I won't, but I could literally tell you, if you make a choice between my medicines and don't smoke, I'll take not smoking, right? So that's important. And guys, unfortunately, it's the same with other forms of tobacco. I don't see many women dipping, so I'm not worried about that. But, within 20 minutes of quitting smoking, your blood pressure and your pulse return to pre-nicotine levels. So you smoke one after the other. I never understood how you could smoke 20 cigarettes in a day anyway. That's a pack, right? I mean, if you're only awake for 16 hours, I mean, that's a lot of smoking. I have people who smoke 2 and 3 packs a day. I'm convinced they can't do the whole thing. They must be just burning down half of it and quitting. But so within 20 minutes of quitting, you can imagine the importance of seeing that your blood pressure and pulse return to normal. Many people who present to the emergency department, when you ask them, were actively smoking when they had their heart attack. What's going on? So that plays a role in it. Within 3 months, your blood circulation and your lung function are already starting to improve. So if you were starting to develop some plaque in your arteries, nicotine works by constricting your artery, or negatively impacts you by constricting your arteries and making whatever cholesterol you have in the artery more quote unquote sticky. So the platelets and the blood clots that like to just normally go right through your arteries will not do that with nicotine. Number one, you decrease the size of the artery by constricting it, and number two, you make it more sticky. So if you're taking a pipe and making it half the size, and then you're putting a bunch of obstacles in there, you can see why we get blood clots and have heart attacks. Within 1 year of quitting, your risk of heart disease is half that of a smoker. Look familiar? 50% reduction in mortality, 50% reduction in having another event. That's why quitting smoking. So if you take nothing, probably this crowd's not the crowd, but if you take nothing more out of this lecture, since you all are at this age look amazing, I doubt you're many smokers, but that's what we're gonna relay it to your kids and grandkids. Exercise. So the second thing I try to talk to all my patients about is exercise. You'll get the gist from this lecture. I'm not at all a pill pusher, okay? I really try to do as much as we can by modifying people's behavior to try to avoid the number of pharmaceuticals that they're on. Why is it important? Regular aerobic exercise of a moderate intensity, brisk walking, stationary bike, swimming, things that are moderate intensity. Obviously you can push them faster, but 5 days a week for 30 minutes at a time, or very vigorous, so 15 minutes a day basically, or 5 days a week, has multiple positive effects. Well, what are those effects? Multiple studies have shown that regimen above, on a consistent basis for 1 to 3 months, will lower your blood pressure 5 to 8 millimeters of mercury, systolic and diastolic. What will the drug companies not tell you? As a former pharmaceutical rep before medical school, I will tell you. That's exactly the number that's necessary to get a blood pressure pill approved. Exercise of that intensity is actually the exact same amount of blood pressure reduction you'll see from many, many pills. That's what they need to prove in studies to show that they're an effective blood pressure medicine. So exercising is just as effective as blood pressure pills. Unfortunately, the benefit's lost if you quit exercising. So you have to continue to do it. But many people, once they've started, very few will stop without an injury. They keep doing it. Cholesterol will absolutely positively be affected by that same exercise regimen. It raises your HDL, which is your good cholesterol. It lowers your LDL, and it activates actual proteins that carry your LDL, your bad cholesterol, to your liver where it's broken down. So in a little different fashion, a lot of your cholesterol is genetic. I'm not going to argue if people say, I exercise like crazy, I'm skinny, and I have terrible cholesterol. I agree with you. I have 100-pound women who have bad cholesterols. I have 300-pound men who have better cholesterol than me. Okay, genetics plays a huge role. But taking that into account, you can improve things. You won't maybe fix it, and we'll talk about it in a different slide, but you can definitely make things better. And so why not have this added benefit that you can lean on if you can use it? Regular exercise also decreases depression levels. So if you talk to a lot of my patients who have significantly sick hearts, estimates right now with congestive heart failure is at least half of the patients suffer from depression. That's a very scary number to us. So if regular exercise can have positive effects for blood pressure, cholesterol, and also increase your serotonin, increase your dopamine, and decrease depression, then it's obviously very effective at helping those people as well. I'm not saying they don't need meds, I don't specialize in that, but another positive effect of exercise. Regular exercise also increases your sleep quality, which also plays a huge role in decreasing the amount of depression people have. As someone who was a resident and a fellow, there's nothing more depressing than not sleeping, okay? Except your wife being mad at you for waking her up, but yourself depressing not sleeping. So we spend a great deal of time talking about trying to be active and exercising, as part of our initial intakes with a lot of patients. Sorry, the delay. Diet. Okay. So I'm pretty impressed with the mac. I'm looking around. It wasn't too bad. I had lots of fruits. It looks like some whole grainish type bread. And what was it? Soup? Is that what it was? Black bean soup. Fantastic. Lentils, beans. Very good. So what do we talk about with patients when we talk about what we want them to do with their diet? First thing, try to reduce as much as we can the amount of saturated fats, right? Try to reduce them. I'm not sitting here telling you don't eat any of them, but reduce them. So try to limit the amount of red meats and full fat dairy products, right? Those are the things that raise your bad cholesterol or your LDL. We all know, I grew up in St. John's in Clinton County. I can show you a string of 85-year-olds who have drank milk right out the cow and done nothing but eat, the meat off their property. And I get it. And there's examples of all that. But in general, in a population, if you're doing statistics, we want to try to lower these levels. And this is one of the ways to do it. Second, we want to eliminate as much of the trans fats as we can. They're sometimes called hydrogenated oils. I think that actually 3-4 years ago, the government said they had to be taken out anyway, off labeling. But so that's things like cakes, candies, pies, fried foods, pizzas, right? It's all of our problem. We love those foods. They're easy. But trans fats, those definitely are things we're trying to limit. They will raise your triglycerides very high, and they will definitely play a negative impact on your LDL as well. So what do we positively want to do, which is what we try to work more on? Well, we want to increase the amount of soluble fiber. So what is that? That's your fruit cups you have there. Apples, pears, bananas, strawberries. We love the almonds and the walnuts. As much of the grains as you can do between oat-based products, oatmeal, oat bran, whole wheat bread, brown rice, quinoa, all those type things. Avocados, avocados are fantastic. We love avocados, a very healthy food. And then flax seeds and chia seeds. If that's something you can do if you don't have some other medical condition that doesn't allow you to have seeds. I do understand some, diverticulitis type things. You can't have seeds and nuts, so be careful with that. But if you're capable of that, these are obviously very, very healthy. I joked that when I started in my group, when I was the young guy, half of my partners were on flaxseed and the other half were on Lipitor, right? So they were all, it depends what stage, I guess, of life they were in. When they're my age now, they were probably doing flax, and if they were older, they were doing Lipitor. So, but there's definite huge advantages to increasing the amount of soluble fiber in your diet. Water. Sorry, say that again. Water. Water is so important. I don't think it gets as much publicity as water should, okay? Obviously, I have a group of people that I have to be very careful of with my congestive heart failure patients. They can't just sit at the water fountain all day long. But if you don't have some other medical condition that limits this, we all should shoot for a minimum of 64 ounces per day. There's no bad outcome to drinking water if you don't have some other medical condition. 64 ounces is 8 8-ounce glasses a day, right? Now, as much as I love coffee, that doesn't count, okay? Because coffee has a natural diuretic in it. So guess what's going to do? Zoop, right? And you all know that. So 8 8-ounce glasses of water. Try to get away from the Diet Cokes I'm doing in front of you, as much of the high sugar juices as you can, and make it much more about water, right? Obviously, it's fantastic for flushing out your system. My kidney doctors, partners, and friends will love you for doing it, help protect your kidneys. It also actually can lower blood pressure, the more water intake. So I put a couple examples up here of diet that probably a lot of people ask about when we're doing different lectures. The DASH diet, if you just look it up on the internet if you want, but basically DASH is built completely around low sodium and a little bit higher potassium foods, bananas and things. I have to be very careful with that in some groups because kidney function, you got to be careful with your potassium intake. But if you have no other medical conditions, the DASH diet is actually proven to be more effective than a blood pressure pill. So it actually has better antihypertensive effects than than a blood pressure pill alone. And that's by lowering the salt to about 1 gram per day. If you've tried, it's very hard. Sorry, it's very hard, but looking at labels. But if you cook your own food and you don't eat out, you can get a lot of pre-processed foods from the grocery store. You can do this. The other one is the Mediterranean diet. We get lots and lots of questions about Mediterranean. I'm a big fan. Obviously, it's plant-based, olive oil-based, very healthy oil. Mediterranean diet is very good for about everything with you. It can lower blood pressure. It's helpful with lowering your cholesterol. It's definitely based on obviously plant-based and seafood, and they have a very good chart. Once a week having red meat. There's some things to talk about. What you can have 3 times a week. What you should have daily. It's very easy to access, but Mediterranean's a very, very good diet. You're 97. You can eat whatever you want if you look that good. Right? I'll make that deal with God right now if I look like you at 97. Weight loss. I put weight loss intentionally at the end. And the reason I do is because so many people focus on the end product and not how they got there. If my patients exercise and they eat the right diet and they stop smoking and they don't lose a pound, they still will have helped themselves, right? This is an added bonus. Don't get me wrong, and we'll talk about the benefits of weight loss, but I don't want to put this first because if that's the goal and you don't reach that, the people will stop the other positive attributes or activities that we want them to do. Why is it important? Weight loss of 10 kilos, which is 22 pounds, is equivalent to dropping your blood pressure 8 to 20 millimeters of mercury. I just told you 5 to 8 is all that it takes to get a blood pressure pill approved. So 22 pounds is exactly the same as and more than lowering what a 1 blood pressure pill will do. So that's obviously very effective. And every 10 kilos, until you become normotensive or normal blood pressure, will continue to happen. So it's not like the first 22, okay, I got my benefit, stop. Nope. If you're 40 pounds overweight and you lose 40 pounds, you lose a couple blood pressure pills worth of blood pressure. That might come in the form of taking away a pill. It might come in the form of now I don't have to add more. It may come in the form of cutting doses in half. Every person is obviously different, but the weight loss will positively affect long-term your blood pressure, and obviously a lot less stress on your heart is how it does it. Weight loss of that same 10 kilos is equivalent to an LDL decrease or a bad cholesterol decrease of 15%. So if your LDL is, let's say 180, right on that brink, 190, you should be treated, which we'll talk about 180. You and your doctor are talking about, I'm not quite sure I want to be on statins. I understand the data for primary prevention isn't amazing, right? So I don't want to do it. Will you lose 22 pounds on average? 15% of 180 is what, 27? So you went from 180 down to 143, 153, nice math, 153. And now all of a sudden you're no longer in the range of someone who needs treated, and you've avoided a statin or any medicine, whatever one they wanted to use. So again, if you're 250 and you're familial high cholesterol, do this to help yourself, but you still might have to take medicine. But if this is the mode that lets you not be on more pills, that's fantastic. Same thing, weight loss and reducing your A1C. I should have been more clear with that. A1C is obviously the marker for what your diabetes level is, your sugar, and so it has the same positive effect. So weight loss, when intentional, is never a problem. We love it as physicians. Obviously makes everything better. But again, if you don't lose weight, but you behave well, you've still done good things. Alcohol intake. This is always a touchy subject. I'm glad it's a lunch, not dinner. So I was joking with Christina. Like I said, I used to do drug rep talks, and then as a rep, and we'd talk about alcohol, and everybody would say don't do it while they had a drink in their hands, right? All right, so what do we know? there's a lot of confounding data on alcohol, but what I will tell you is that the majority of studies show the cutoff for risk lies about 2 drinks per day for men and 1 day for women, 1 a day per women. Okay. I have lots of people who like to have a glass of wine each night. I always talk about it. As long as that glass is only 6 ounces and not the whole 750 cc's, right? The glass is not the glass bottle it came in, right? So whether that's a beer, a shot, or a regular sized glass of wine, 1 glass a day probably does have some health benefits to you when it comes to things like raising your good cholesterol. But it is extremely slippery slope. It goes downhill very fast once you drink more than that. So if people say I like to have a drink a day, I don't argue with that, you know, if they're doing the other things. There's small benefits, like I said, in raising your good cholesterol. The problem is if you drink too much, we just did everything we talked about not doing, right? We're gonna raise your blood pressure. We're gonna have weight gain with all that extra calories. And there's actually some cardiac toxicity that comes along with excessive alcohol. You can actually, you know, make your heart muscle weak. There's a group of people that excessive alcohol will make their heart muscle weak, and that's a heart failure you don't want. So again, it's an odd group to bring it to because you guys are doing amazing at your ages, but you know, try to keep the alcohol to 1. And obviously directly related to what we call atrial fibrillation. So alcohol is one of the 7 causes we talk about with patients if they come in for atrial fibrillation. And it's specifically associated with excessive amounts in one time. So you're like, I don't drink all year, and I've done this numerous times, admitted people I know well who don't drink all year, but at the holiday party, they had too many, and all of a sudden the next day or two, they're in atrial fibrillation. Sorry, it's breaking up. They're in atrial fibrillation. So try to avoid excessive times at any time. That is not in your best interest. So to kind of go over some of the risk factors now that we've done some of the modifiable things we can do by behavior. So obviously we talked about hypertension control. So exercise, so important. We talked about the 5 days, 30 minutes at a time. We talked about what the weight loss could do for us. So what else can we do? So eat a lot of the omega-3 rich foods, salmon, herring, walnuts, flaxseed. So these are some of the very easy ways you can lower your blood pressure through your diet. You don't have to go out and do fancy medications a lot of time, especially if you're on the borderline. Low sodium, we talked about DASH. I just put the little caveat in there. Please consult with your physician if the potassium's an issue, especially if you are a kidney disease patient. I don't want that to be an issue. Limit your alcohol intake. We just went over quality sleep. So 7 to 9 hours. It's very important. Sleep is very important and probably one of the most under talked about things in medicine. And how do I know this? Because the next one that is identify and treat sleep apnea if present. Sleep apnea, if that's when you stop breathing at night or your oxygen drops, a combination of either or both, is one of the reasons what we call of resistant hypertension. So when a person comes to me and they have 4 or 5 pills and their primary doc says I can't get their blood pressure under control, one of the first things that goes through my brain is, do they have sleep apnea? Used to be there was a body type. Unfortunately, that's not the case anymore. 25 to 30% of sleep apnea patients have normal BMIs and normal neck sizes. So it's not the 300-pound gentleman whose wife's ready to divorce him because she can't sleep because he snores all night. That's not the case. The last person I did, 120-pound female. Stop breathing 37 times an hour, right? You're not statistically going to die usually from sleep apnea. It's usually not that bad a case. Yes, we read about 500, 600-pound people who die, but that's the rarity. But what happens is if you stop breathing that many times per night, your oxygen drops. Well, the heart hates having low oxygen. It doesn't care why it's low. It doesn't, whether it's not breathing or blocked arteries or your bad COPD or whatever the reason is. Well, what does it do in response to it? It raises your blood pressure to try to get more circulation. Well, you can imagine the fight we're fighting if we're trying to lower your blood pressure, but what we're fighting is an untreated sleep apnea. So many people now home studies or in the hospital studies to try to eliminate that as the cause for high blood pressure. And when I teach the fellows, it's not about body size anymore. If it smells like a duck and walks like a duck, right? Check it. Okay, check it. Then the last step is medications is necessary. There's 4.7 million pills for blood pressure on the market. There's so many, I'm joking, but there's, you know what I'm saying. There's blood pressure pills, literally, I'm not joking with you. I started being a pharmaceutical rep in 1993. Medications I sold then are still medicines I use now. 30-year-old medicines for blood pressure. But that's a last step if we've tried everything we can to get our blood pressure less than 135 over 85. That should be our goal. Cholesterol. Obviously, cholesterol plays a huge role in this. I know there's a lot more to it. This is a lecture of an hour by itself. Right? This is a whole lecture in an hour to talk about cholesterol, inflammation, genetic factors, lipo(a), apo(b), all the subfractionation. We could do an entire lecture for an hour just on this. But I just want to stick to some of the basics when they talk about how are we going to treat it. You don't have to, there'll be a test as you walk out. You'll have to remember this, okay? The gist of this is anybody between 20 and 75 that's bad cholesterol is over 190 should be offered treatment. That doesn't mean we give up on you at 75, but that means that's a discussion with the doctor. If you're 82 and have never had a problem, there's a reason you're 82 and never had a problem. Maybe you don't need to have your cholesterol lowered anymore. Maybe that. Now, very few people anymore are 82 without just finding out their cholesterol is bad, all right? That's rare. So patients between 40 and 75 with diabetes or peripheral arterial disease, they should be treated no matter what. We treat people with diabetes as if they've had a heart attack because they don't like to hear it, but they will. So we treat diabetics as if they have heart disease already, so we lower their risk. And then patients with diabetes and their LDL is intermediate, they should be treated to try to get it down to without diabetes and that goal. And we should be talking about if their ASCVD risk, which is what we use over here, that's the calculator. We use age, gender, what's your blood pressure, are you a smoker, hypertension. We put them all into a fancy little calculator on the computer or in our phone. It spits out what your 10-year risk is. If you're high risk, clearly you need to be on it. If you're low risk, the data says you don't. If you're in the 10 to 15, 10 to 20% range in the next 10 years, then it says you should have a discussion about treatment. I'm a firm believer the treatment starts with what we talked about before. Weight loss, diet, exercise, recheck it in 3 months. People will oftentimes be very disappointed. They do all the right things, but genetically it's still going to come back the same. But you've still done the right things, at least got it going in the right direction. Then we'll talk about statins or injectable PCSK9s or Leqvio once a year, all the different options that are out there. The role of the calcium score is an interesting thing, and this is something that's done in people more my age. When you have cholesterol, we're trying to decide should we treat or not. We'll put them under a CAT scanner with no contrast or anything, just literally with one puff, take a picture and see if they have calcium on their arteries. If their calcium score is 0, there's no benefit to statins because their 10-year risk is basically 0. If their score is anything more than what we call 100 or 75% adjusted for their age group, then we have to have a discussion about, I know you're 55 and but this is your cholesterol and this is your calcium score, you should probably be treated. Many people still tell me no, and that's okay, but they have the data in front of them. It's going to say diabetes in a minute. There you go. Diabetes. Obviously, diabetes is, I would say, the 3 biggest risk factors for having heart disease and vascular disease are in order: tobacco abuse, diabetes, and peripheral arterial disease. So if you have diabetes, we treat you, like I said, as if you already have blocked arteries. So they should be treated for their cholesterol, unless for some odd reason it's super low already, which we almost never see with diabetes. But So when I talk about A1C, that's your hemoglobin A1C, that's how much glucose is attached to your hemoglobin over a 2 to 3 year range. The reason they came up with this test is because diabetics would cheat the day before they had their labs done, and they would go in and not eat sugar, and their labs looked great. I would too. So they developed this. This is a 2 to 3 month average, 60 to 90 day average, and you can't cheat this one. Okay, this one is, like I said, this one's more of a long-term measure. There's the different measurements if you ever want to know what your number is. Greater than 6.5 means you're diabetic. Why is this important? Each 1% increase in your A1C is about on average a 20 to 22 point increase in your regular fasting glucose, is a 14% increase in your risk of a heart attack or stroke. So you can see going from 6.5 to 8.5 is almost a 30% increase. 3 in 10 people will have more heart attacks or strokes. That's obviously not what we want. The good news is the inverse is true. So if you come to me at 9.5 and we spend the next 6 to 9 months working on everything we want to work on, and you come back and you're at 6.5, you've in essence reduced your rate by 42%, 3 times 14. So that's why. What do we want to do? Obviously everything we've talked about, the weight loss. Exercise has an extra benefit in diabetics that it increases insulin sensitivity. Again, diabetes is an entire maybe 2-hour lecture, but one of the obvious abnormalities besides the pancreas not making enough insulin is that your body doesn't respond to the insulin well that you make. So if you exercise, you actually make the body more insulin sensitive. So that actually will lower the amount of the sugar in the blood. Exercising, same thing, 30-minute brisk walk per day. It lowers your risk of a sedentary lifestyle 50 times more than a person who doesn't exercise. So it's got a great benefit. Now 50 is a little misleading because if it's 0.02, it goes to 0.1, right? I mean, so you got to be careful what 50 times means, but it's a massive decrease. Medications after all the above, and nowadays we actually prefer agents that are both cardiac and kidney protective. It's interesting, the 2 best heart medicines that have come out in the last 2 years are both diabetes pills. Yeah, Ozempic and Mounjaro in one class, and Jardiance and Farxiga in the other. So these show you the interdependence between diabetes, vasculature, kidney disease, and these medicines have they've changed the game. I had one patient I saw a couple weeks ago. They went on, it doesn't matter if it's Mounjaro or Ozempic, one of those 2 drugs. Over a 9-month span, they lost 80 pounds. They were on 7 pills, 4 blood pressure pills, 2 diabetes pills, and a cholesterol pill. They were on none of them. All of them went away because of the weight loss. So, when we talk about weight loss being important, however you get there, I'm not to judge whether it's the others or you do it through diet and exercise, that's between you and your doctor, but it does matter. It matters that you get there. Supplements. I always get good questions about supplements, so I figured I'd head it off at the pass. Fish oil. Fish oils, it's interesting. I always joke when I've been doing this between my residency now 26 years. When I started, estrogen saved all women. Midway through my career, estrogen killed all women. And at this point in my career, estrogen is neutral. So I figured about another 5 years, it'll save all women again, right? But fish oil kind of carries a similar path. Every couple of years, someone says, oh my gosh, it's going to be the panacea. The truth is, if you don't want to do anything else, if you take fish oils over the counter, omega-3s, krills, whatever you find at GNC or any of your favorite stores, it will help with your triglycerides, and it will probably keep your HDL and your LDL at a good level. It's not going to massively change them, but it will help keep them steady. But the triglycerides is where you'll see. Be careful with fish oils if you're on other blood thinners though, okay? So if you take blood thinners for a different reason that's not heart related, say you have blood clots in your legs, blood clots in your lungs, some sort of clotting disorder that hematology takes care of, don't just randomly add fish oil to what you're doing without talking to your doctor. It can make you bleed. CoQ10. CoQ10 gets a lot of publicity every 4 or 5 years. I always joke it's because someone else starts making it. But the truth about CoQ10 is they've tried over and over to prove that in studies that it helps your heart. Unfortunately, the studies have not proven that to be true. The one place that I am thoroughly convinced, as of most of my partners and at many medical conventions I've been at, is it does help with statin-induced muscle weakness and muscle destruction. It does help with the antioxidant part of that. So if you say, they have you on, I'll just pick a drug, Crestor or something, and all of a sudden your thighs are marginally hurting, not killing you. I want you to stop the drug if it's killing you, but if it's like I really am cramping up, one thing is you can try CoQ10 if that drug is really necessary that you're on the Crestor or Lipitor, pick your drug, okay? That is one place it does work. Magnesium. Dr. Schaefer, my partner, is a magnesium lover. I have people who absolutely hate it. So even within my own group, there's varying opinions. But what I will tell you is the most important thing is make sure you get magnesium diets in Michigan are very poor. It's not something that's in a lot of the food that we eat. So at least make sure your levels are normal and or at least make sure you're taking a multivitamin a day that has some sort of magnesium involved in it, okay? Because magnesium is imperative in everything that has to do with your heart rhythm, with calcium, with potassium, and it also plays a huge role in part of transporting those across the cell membranes. So if someone has a lot of extra heartbeats, safely, I've done all the testing that they're not in trouble, but safely have a lot of extra heartbeats, I'll sometimes recommend that they try over-the-counter magnesium. The side effect is paying for it, right? It's not going to hurt you. So if cost is the worst thing I'm worrying about, and a generic magnesium is not going to be that much. Probably a third to maybe, if I'm being very generous, a half people will say they see some reduction in extra heartbeats with magnesium over the counter. Red yeast rice absolutely works. But don't come tell me you don't want to take a statin, you'll take red yeast rice. Because red yeast rice has Mevacor in it, which is a statin. So it's the same ingredient, just to a lesser extent. So you can expect that you might have to worry about muscle aches with red yeast rice. It's just about like 30% content of what the real pill has in it. But it absolutely will lower your bad cholesterol. And if you have a marginal one, and that's all you need, you just want to do over-the-counter red yeast rice, absolutely fine. You can try that. It does not hurt you. The one I seem to get a lot of the last couple of years is this vitamin K2. A lot of the things must be in Facebook or something, the ads that pop up that talk about heart healthy with vitamin K2, because we do get that question. So what I would tell you about that is their claim is that it keeps the calcium in your bones and not circulating where it would deposit in your arteries. In theory, that sounds fantastic. I agree, that's not bad. The best I can tell you is maybe. We don't have good long-term studies. That doesn't mean it doesn't, okay? Be careful with studies, because studies are done with people who have a lot of money to try to make more money, okay? That's the problem with a lot of that industry. I was actually part of it, so I can tell you, right? That's where studies come from, unless it's truly being done by NIH or someone who's not trying to make money on it. So just be careful with vitamin K, because obviously vitamin K causes, and you got to be careful about it. Coumadin is a vitamin K blocker. That's why you're a blood thinner. So vitamin K, you just have to be careful about not take more than it tells you to. In TMG, I'd never been asked about this before. This one was about 2 weeks ago, so I threw it in there. Homocysteine is a natural chemical in your body. If you have too much of it, it makes you form blood clots. So this one claims that if you take this, it will form less blood clots by breaking down homocysteine, if you want to know. So in conclusion, obviously heart healthy maintenance begins with self behaviors. I'm a big believer that's exercise, diet, tobacco abuse, and your body habitus. The one thing we didn't talk about, but central obesity. So being built like an apple versus a pear is worse, right? And apples come with more diabetes. That central obesity, that probably is the correlate. So trying to do whatever you can, I see it from my generation, sadly more than yours, is what pill can I take for this, doc, right? You guys are not about that. My generation is, unfortunately. So good for you all. But trying to do this more than jumping right to pills. Medications provide an adjunct, all right? Now, sometimes we'll have familial cases, like I said, and you can't avoid pills. No matter what you do, your cholesterol is terrible, your blood pressure is terrible. your diabetes, this does not count type 1s. Type 1s, it's not their fault. That's the type 1 diabetics did not earn that. Okay, we don't count them when we're talking about this stuff. That's stuff from young age where their body, betrayed them in making insulin with their pancreas. That's not their fault. But everything else, we can modify these things through the work. And we have to do something because the burden to the society, if it's 500 billion now, it's $1 trillion in 10 years, right? And so, there's only so many resources to share around. So if we can modify those with our behavior, we should be trying to do that. American Heart Association, CDC, Mayo Clinic, American Diabetes Association, anything you want to look at, they're fantastic resources for all of this. That's it. Thank you. Questions? I guess my voice wasn't. Yes. Yep.
With the legalization of marijuana, are you seeing any change in your practice?
Yeah. The question was, with the legalization of marijuana, am I seeing any change in my practice? This is personal opinion. I want to say this right off the bat, okay? My personal opinion first on the legalization of marijuana is I would much rather have you do that than take OxyContin and some of those other drugs that are used there for pain relief, right? What I ask of my patients when they tell me that is I ask them not to smoke it. So the inhaling and what goes into your lungs is awful. Marijuana in itself, THC or whatever, the product for the pain control, obviously stimulants for cancer patients, dear God, please, yes, take it, those type things. But all I ask them is not to smoke it, that's an issue and that's not good for your lungs. I don't want to give an age. We had a young person come in vaping the other day whose lungs were entirely full and had to be transported to Michigan within hours or probably would have died if they didn't get what's called ECMO. So anything you put in your lungs, vaping is not safe. It's not a way to stop smoking. Smoking marijuana is not a great idea, but the edibles and those things, if that's your way to avoid some of the other medications that are so addictive and we die from or get mixed with other stuff, this is my personal opinion again, not Michigan or Sparrow or anybody else, but I would prefer they did that than the other. Yeah. Yes.
Calcium scoring tests.
Yep.
So I've heard people say you can not covered by insurance. Is it worth it? Do you recommend it?
Yeah. So great question. The question was calcium scoring. So in 2005, I brought calcium scoring and calcium studying of the heart to Lansing. I actually did that in my fellowship and brought the technique back to here. So that is kind of my area of expertise. There's two different tests. The first test is where we actually go in and look at your arteries non-invasively. That involves an IV contrast. So that is where the 58-year-old person has an abnormal stress test, but you're not quite convinced, I don't know if that's true or not, but they have some risk factors. Before we put them through an invasive heart catheter, let's do this CAT scan. So in that one, we actually look at the arteries of your heart. The second kind is what's called a calcium score, is what you referred to, a coronary calcium score. That one involves no IV, there's no contrast. It's a very, very less radiation than a flight to Los Angeles. It's almost no radiation. And what that does is you literally just lay there and in one heartbeat, it takes, I always say a puff, but the CAT scanner takes an image of your heart. It does not tell you if you currently have blockage. It tells you how much calcium is on the outside of your arteries. And it tells you in relation to a cohort of your own age-adjusted people, what is your risk in percentage. I utilize calcium score for people who are middle-aged and trying to decide if they want to be on cholesterol pills or not. Once you become 70 or older, you should have calcium. At that point, it shouldn't be determined by a determining factor on whether you treat or not. That comes down to your cholesterol and your decision with your doctor based on your other risk factors and what's been happening. But anybody in that 40 to 65 range, if they have a cholesterol that's borderline about being treated, I'll use that calcium score as a way. A couple of years ago, Sparrow, it wasn't actually their fault. They just didn't know it. They were charging like $2,000 for it because they just charged like a regular CAT scan. Myself and Dr. Hansen, my partner, they had no knowledge. They didn't even know. And so now it's $100. $100 out of pocket. We always joke, come with your credit card. No one cares. They laugh. They think that's funny. But $100 and almost everybody's willing to do that Because if you're in my age range, $100 is nothing compared to not being on medications long-term if you don't need them, right? Many people choose to just do them on their own to find out too. I get lots of consults or phone calls actually from people my age, like, what should I do with this, Matt? Yeah, go ahead. Yeah, go ahead. Yep.
I actually had the calcium score.
Yep.
I paid $100 for
Yep.
it. And I had the exact same. I understood the limitations after I had the test because I have very high cholesterol. It can't. But then there's the on my test results. It says check. It only checks for the presence of calcified plaque. It does not show or test for blockages.
Yep.
So I was wondering what the difference is, and
Yep.
it sounds like what I really need is with the IV in contrast.
I would not do that first one if you're not having symptoms. I would not do the full test.
So that's for symptoms only.
So calcium score, the bailout they're trying to do that is some lawyer speak that basically says this does not test for soft plaque and or if you have any evidence of blockage, right? But the statistics are if your calcium score is 0, your 5-year risk is 0.1%. At 0.1%, I would never do another test. Personally, it was so outside the guidelines that I had to do something, or I was diabetic or bad family history. So a calcium score of 0 in almost everyone that I know's practice is you're fine.
And a quick follow-up.
Yeah.
My understanding is that the calcified plaque is more stable than the soft plaque, and so just because.
Right.
What is the level of my soft plaque and the risks
Yeah.
involved with that? And how
Yeah.
does that get measured?
Yeah, so soft plaque is the cholesterol inside the arteries, right? And so you're right, you cannot tell from a calcium score if you have that. But again, through 25 years of data now with calcium scores, we know that if your calcium score, it's never 0. There's never 0, right? I can tell you in the first 5 years I was doing them, I had one nurse who was 45 years old, and she kept getting told by other people, this is not your heart, stress test fine, calcium score 0, yada, yada. Finally did the second CAT scan because no one wanted to cath a 45-year-old female, and she had about an 80% blockage in her LAD. That's why it's 0.1, right? That's why it's 0.1. But the statistics say you do not need further testing if your calcium score is 0 and you're asymptomatic. Yeah, absolutely. And your first question about calcified plaque being more stable, careful with that, but there is some truth, okay? So the truth is, if you have an 80-year-old patient who has calcified 3-vessel disease, right? The likelihood is that's less likely to rupture than a 52-year-old who has one blockage that's about 60% in cholesterol. It all goes to lecture on cholesterol and its makeup, and Dr. Strobel, my partner, who's the cholesterol expert in the area, will show you wonderful pictures and electron microscopy. Cholesterol plaque is made up of a lot of cholesterol, but a very thin coating. That's more likely to rupture and cause a heart attack. Because unfortunately, more than half the heart attacks that happen at less than 50% blockage. They're a 40%, 30% cholesterol, but it breaks and fractures for some reason of stress, whatever that cause is, and then you send a blood clot there because it thinks you're bleeding. Calcific plaque is more thickened and thicker caps in comparison to the amount of cholesterol that's in that and less likely to rupture. Yeah, of course.
Blockage in the veins because of cholesterol.
Mhm.
Are we simply trying to get past the cholesterol, or are we able to reduce the amount that's already there? Is it there to stay, or we can reduce it?
You or me? So me with stents, I can fix it. No, that's a great question. So the data basically right now that we're working on is that if you get your bad cholesterol down to 40 or 50, we believe that there is a reversal of the cholesterol. So the interesting thing about the statins, and I know they're a hot button issue, so I'll be a little careful with them, but the interesting thing about statins is if I give 100 people statins, and I give 100 people rabbit food, and I give them their LDLs both to the same low level, the people on statins will have less heart attacks. And the reason is they not only lower cholesterol, but so they make it less likely to rupture. So yes, we want the long-winded answer to your question is we believe there can be reversal if you drive your LDL back to what I call prehistoric times when it was 40 and 50. Yep. Yep. Absolutely. Go ahead. Another question? Yeah.
Yeah, Doctor, would you comment on, there seem to be some confusions. Some medical people say that you should be on Eliquis, and others say, oh no, that's too expensive. Why don't you just go on aspirin? It's the same thing. Could
Yeah.
you comment on
Okay,
that?
a whole different lecture. I'm happy to give you the brief synopsis of that one. Aspirin and Eliquis are used for two completely different things. So baby aspirin is used for things like blocked arteries. You've had a stroke because of blocked arteries. Eliquis, I'll give full to everybody. Eliquis, Xarelto, Pradaxa, and old school rat poison warfarin are used for a different reason, and the majority of times that's for atrial fibrillation. Aspirin does not work for atrial fib. Don't let anybody tell you it works for atrial fib. They did 18 studies of it, 17 it didn't work, and 1 they lied. So aspirin does not work for atrial fib. So if you have a fib, you need to be on, there's more that goes into this, but in general, you need to be on Eliquis or Xarelto or Pradaxa or warfarin. The aspirin comes in, we do both, yes. So if you've had a heart attack and had a stent in the past, and you have a fib, we will use baby aspirin in addition to Eliquis together. Yeah, absolutely. Now, obviously, we have to be very careful. The bleeding risk is higher being on both. The current thought process now is that long-term in studies, can we get rid of the baby aspirin and do Eliquis only for both? So while aspirin doesn't cover the AFib, will Eliquis and Xarelto, though, cover the blocked artery part, and we don't have to do baby aspirin in addition? I'm sure you've all seen the thing that says don't take baby aspirin, right? And there is some truth to that. If you've never had a heart attack or a stent or a stroke, baby aspirin isn't indicated. So it is not for primary prevention. So there is no benefit to taking that on a daily basis. Actually, the risks outweigh the benefits if you've never had an event. I just wish that the USA Today Medical Journal would be a little more forthcoming with who should quit, because I've had 3 or 4 people in my career stop baby aspirin because they read it somewhere and came in with a heart attack. So the qualifier is if you've had bypass, if you've had a stent, if you've had a heart attack, if you've had a stroke, you should be on baby aspirin unless your doctor tells you otherwise. Yes?
How close are we to an ingestible solution for LP-A? What are your general thoughts on LP?
Yeah, LP-A. Always love this one. So statins don't work for LP-A, right? They don't. So one of the reasons that people take statins and drive their LDL down to 70 but still have heart attacks is because LP-A and to a lesser extent ApoB, the fractionated portions of the cholesterol, which are mostly genetic, they're not treated by statins. So if I have a patient who comes into me and their LDL needs treated and I subfractionate it and their LP-A is high, I actually don't use statins anymore. I use Repatha or Praluent, the injectables, because they lower it. So I have not heard of any ingestible. All I know so far of lipo-A for the main treatment right now is the injectables. I'm sure somebody's trying to make it, like they were trying to raise HDLs until it killed people's livers, right? I mean, there's always attempts for these things. But right now, if you tell me that, especially someone who's at high risk, high risk, bad LDL and 150 to 200 plus lipo-A, I go right to Repatha and Praluent, which are the injectables you do every couple weeks. Don't do the statins because they don't treat it. I have to fight with insurance companies, but I show them why, so. Yeah. Yes?
I have high blood pressure, and my top number is high, but always the bottom number is 60.
Mhm.
So
Yeah. Yeah, so we call that a wide pulse pressure, which is a big difference between top and bottom. There are a couple things that need to be checked. You need to make sure your aortic valve is okay. So hopefully someone's doing ultrasound on your heart at some point or listen to a murmur. But the other thing we often see is that that can be indicative of the fact that you just have smaller arteries. The diastolic or the resting one does okay, but that initial one, the systolic or with the heartbeat, is higher. So, but you definitely need to treat that still. You You never stop treating because the bottom's too low. You always want to make sure that top number gets at least below 140, if not 135 if you can, absolutely. But if you've not had an echo and if you're sitting at 150 over 60 or 160 over whatever that blood pressure is, you said the top number is high and the bottom is 60, you need to make sure somebody has checked an ultrasound of your heart and make sure you don't have a bad valve in there. Yeah.
How long is too low for your bottom number?
Yeah, that's a great question. Yeah, so the diastolic, there's some of us who believe that there's not really that many people pass out from the bottom. It's more the top, you know, as long as the top number's high. I think if you get less than 50 on the bottom, you should probably talk to your doc why it is. Because if you have a normal pulse pressure, if your bottom's 50, the top's probably 100, right? And so that's probably too low. I work under the, you know, unless you have congestive heart failure, which is an entirely different topic. But if you have a normal heart, we don't need to drive your blood pressure down to 100 over 60 or 100 over 50. And when I started practicing, they used to say 100 plus your age was okay, all right? So I don't even like that. I'm not going to go around the room. So I think the key there is making sure both together are not too low, okay? Because otherwise, if the bottom alone is too low, something else is going on that they need to sort through as to why are you 120 over 40? You shouldn't be 80 points between the top and bottom. I'm just using an example, of course, but you know, I think in general for blood pressure, you treat both numbers. And as long as you can keep it under that, you know, 85, keep it 70s and 60s, that's where we'd really like to see it, as long as the systolic's not too high. Yes, sir.
Something you didn't touch on in this session, but carotid artery, I've been interested in. Well, say a guy 80 years old, his cholesterol levels are, well, nice within the range, and he's been told he has a 50% blockage of the carotid artery. So how long will it take? I know it took 80 years to get there. That's one thing. If it happened in the last 2 years, that's another matter. So
Right.
maybe can't give a finite answer, but I was interested in person, good diet, everything else, the numbers are not that bad. How much concern? How long could it maybe go before should really be concerned?
Yeah, so carotids are a different story than coronaries, which are heart arteries, because they're so much bigger, right? And so we tolerate a lot more blockage. In fact, there's a trial coming out pretty soon called CREST-2, which is probably the most in-depth study of carotids that's ever been done. And those of us who kind of know some people are probably going to hear that medical therapy is as good as most of the surgeries and stents until you get 80% or more. So the current data is that if you're at 50 or 60% and symptomatic, so having stroke-like symptoms, you should have it treated. But if you're asymptomatic, you shouldn't do anything except medical therapy until it's at least 80%. So carotids are different. Again, carotids are different. And when you get carotids, you have to be very careful about what the modality was they told you the blockage was. So an ultrasound of your carotids is it's good. But remember, how we measure a blockage is we measure the blood flow speed in the artery in your neck. So if you think about sticking your thumb over a hose, you've blocked the hose, right? The water comes out very fast. It's a similar process when you talk about the carotids with ultrasound. We measure the speed of with the ultrasound probe, we measure the speed of blood in the carotid artery, and we give you a range. It's 0 to 50, 50 to 70, 70 to 90, and right? After that. And so to say I have 50%, I wouldn't even think twice about it. I wouldn't even check that for 2 more years. I wouldn't think twice about 50%. You start getting up near 70%, and I'll check that yearly, and I might even do a CAT scan, which gives me an actual number. And the hard part about it is there's a lot that goes to the carotid arteries, and that is that it's not a straight tube. Oftentimes you'll have a bend, so the speed can be altered by what is the mechanism. I've literally seen curlicues in the artery. Sometimes the speed is actually blunted because there's a blockage upstream before you get to the carotid, the internal carotid, which is what you care about. If the common carotid has a blockage, it may not be accurate. So if I'm absolutely concerned or people are having symptoms, I'll get a CAT scan to look at that. But 50% in and of itself I just make sure people's cholesterols are well controlled. I don't even check that for a couple of years. Yep, of course.